Okay, hello everyone. I'm Lele Sigwebela. I'm a research officer at the Perinatal Mental Health Project at UCT. And we address the problem of widespread common mental health conditions amongst pregnant women and postnatal women in low resource settings. And we do this by supporting the integration of quality maternal mental health care into existing mother and child initiatives. So today I'm going to be speaking on the community health intervention through musical engagement, CHIME, in South Africa. I know a few of you have been to a previous presentation on the workshop, but today I'm going to be talking about the results of our investigation with our key stakeholders. There are mental health problems in the perinatal period are a particular challenge in low and middle income countries. And there's a high prevalence of common mental disorders in Southern Africa during the perinatal period. And in much of South Africa, mental health services are minimal, and there are high levels of stigma associated with mental health issues that impede recognition and prevent help-seeking behaviors. There's also a greater focus on the physical outcomes of mothers and their babies. However, we know that stress, anxiety, and depression in pregnancy and after birth can affect not only the mother, but can have long-term adverse effects on her child. So it's a high priority to develop appropriate interventions to reduce symptoms of anxiety and depression in pregnancy and postpartum. And research in community and perinatal mental health interventions in low and middle income countries focus on educational and psychosocial interventions delivered by non-specialists using talking therapies and peer group-based approaches. Research has also shown that singing in groups can be beneficial for supporting women's mental health during and after pregnancy. So CHIME was initialized in the Gambia through a PhD project. CHIME Gambia focused on a novel approach by using women's community music groups called Kanyaling groups as co-developers and co-facilitators of a maternal mental health intervention. The Kanyaling groups comprise of women who have personally dealt with infertility or child mortality, and they play an important role in their communities. The intervention was delivered to all women attending antenatal clinics across 4 sites over 6 weeks. And overall, there were reduced symptoms of depression and anxiety. The project is now expanding to other low and middle income countries like South Africa and India. As we know, South Africa is a diverse country with 12 official languages and a corresponding amount of ethnic cultural groups. South Africa is also one of the most unequal countries in the world, and much of our population lives in poverty, where access to resources and health services is varied and limited based on your location and socioeconomic status. South Africa also has a long history of music making and oral tradition, particularly during times of hardship and as a tool for socio-political commentary and more positively social cohesion. The use of songs and instruments to accompany dance is a shared common characteristic of South African oral tradition across ethnic groups, as well as in urban and rural settings. So our study was designed in 2 parts. So the first was a formative investigation with key expert key informants to synthesize the existing knowledge and inform the co-design workshop. We held 5 focus groups with 5 groups of experts. And this is what we're going to be focusing on today. And then based on the information in part 1, part 2 aimed to prototype and co-design a music intervention with community health workers with our collaborators from One-to-One Children's Fund Africa. We partnered with a community in Mankosi, Eastern Cape, with One-to-One Children's Fund Africa, where they train and employ local women as community health workers to deliver door-to-door health and social support services. These women have developed an existing spontaneous musical engagement practice to deliver public health messages to the community, and they were natural partners for the co-development of and development of South African version of CHIME. And then we used experience-based code design as a theoretical framework for both parts of our study. And experience-based code design is an adaptable multi-approach method to improve healthcare services through participatory action and code design. And then we did after the 5 focus groups, we did thematic analysis Some of the transcripts were in Xhosa, and so we had those translated verbatim in Xhosa and then transcribed in Xhosa and then translated into English. So there were 2 independent coders for all the English transcripts, and then there were 2 dependent coders for the Xhosa transcripts. And then we resolved all the codes in English. So our key informing groups were one-to-one management, the NGO we collaborated with, musicologists and musicians from universities across South Africa, community health workers from one-to-one, traditional healers, and health workers from different parts of South Africa. So we did the thematic analysis, and one of the ideas that emerged was that there are challenges that contribute to mental distress throughout the perinatal period. These challenges are listed here on the right side of the slide. And these challenges result in unhelpful coping strategies to manage mental health. Interestingly, the coping strategies are often misunderstood, and this makes the mothers become further isolated and ostracized and stigmatized by their social support circles due to a lack of education and information about how these challenges affect their mental health. On the left here is an excerpt from one of the focus group discussions. So I think emotionally, it's the things that we kind of expect in the relationships, then later on they turn out not to be what we really expected. Then once it doesn't work out, of course, one will go to the tavern and drink a lot of alcohol, take drugs, and end up leaving home because whatever that you were expecting didn't go the way that you were expecting to go. So it's important to acknowledge that these unhealthy coping strategies are a symptom of the environment the women and their families live in. These are systemic problems that can't be simply changed by the mothers and their families alone. I mean, more than half the South African population lives in poverty, where access to water, food, electricity and housing is limited. And as you move away from the urban and peri-urban settings, these resources, including access to healthcare services or any formal mental health care, diminish further. And this is influenced by the racial and systemic oppression of people of color during apartheid. And the restructuring, redeveloping of these communities requires time and access to resources, and it's still an ongoing process. But many of the communities and families still feel the effects of this regime, along with the effects of patriarchy. The intergenerational trauma persists, this provides a context to the high levels of intimate partner violence and substance abuse rates in our communities. So another idea that emerged is that there is a need to rebuild social connections in a safe, fun, and comfortable space. So these social connections were described as being built through group activities, which already exist in cultural ceremonies and in religious gatherings, but it was described as a space for pregnant and postpartum women to be amongst each other, doing something other than their real life social responsibilities. So I'm going to use 2 excerpts to explain this safe, fun, comfortable space. So as for me, I think one of the things that could help for them is a support group for those who are pregnant and those who have delivered, where there will be fun. This is described by this was said by one of the community health workers. So this word, it's a Xhosa word that describes joy, lightness, fun, and happiness, which can mostly only occur in a safe and comfortable space. Where you discover another excerpt from the community health workers is where you discover my problem is smaller compared to someone else's. I thought mine was bigger. It's smaller because the other finds out that it is bigger than mine. In so doing, each and every person feels free now and sees that, no man, let me join the other kids. And I am the same as other kids. Here, the community health worker is talking about how if you share your experiences, you free yourself and you realize that you're not an embarrassment. Another concept that is shared here is through the word nipefumelana, Ukuphefumulelana described is in English breathing on each other, but what is described here is that kind of close conversation of sharing and being vulnerable, which kind of indicates that this space is safe and it's very comfortable for people to share their experiences and let go of the pressure that they're feeling. So there was a consensus that group activity is the best tool to get people to share or feel supported. Music making was selected as a natural group activity. It's the easiest being in a group because of its participatory nature. People can harmonize, clap, or dance as they see fit. And the benefits of group singing from the data are outlined here on the slide. So the final theme that emerged was that group singing is healing, flexible, and used to express emotions and attention. And group singing acts to promote social connection, agency, and self-esteem. As we know that there are existing group-based musical practices in South Africa. They exist both in formal and informal settings, in the clinic and outside the clinic. We know that music, from the data, we know that music can have a powerful message and that group-based music can have powerful effects on healing. In closing, I just want to close with a quote from one of the musicologists and musicians. He said, "So that is where I saw the power of music and came to the conclusion that music does not heal, but prepares the mind for healing." So thank you so much. Thank you to our team, our collaborators and our funders, to our research assistant, Numisa Waluwalu, our focus group participants, and Noma Moshani for her transcription and translation services. Thank you.
Thanks so much, Leila. It's such a powerful intervention, and it's nice to sort of hear all the rigor and the quality research that went into designing this intervention. Bronwyne, are you online with us?
Yes, I'm here.
Wonderful.
Hello,
all right.
everyone.
Hi. So Bronwyne, while you're sharing your screen, I'll just introduce you briefly. So Bronwyne is a senior lecturer in the Department of Psychology at Stellenbosch University, where she teaches child development and child mental health at an undergraduate and postgraduate level. Similarly, her research interests are very much focused on children's mental health and well-being, with a focus on prevention and early intervention. So welcome, Bronwyne.
Thanks very much, Kat. Are you able to see the slides in full view?
We can't see your screen. I can't see it anyway. Can we try sharing again? I did make you a co-host.
Okay, so it shows to be sharing on my side. Let me see what's going on.
Oh, there we go. It started to share. There we go. We can see it now.
And is it in full view?
It's in full view. Perfect. Thank you, Bronwyne.
Thank you, Kat. So good morning, everyone, and happy World Mental Health Day, where our pursuit, I guess, is towards making mental health and well-being a priority for all. And certainly through this work, we hope to contribute to some of those efforts. And this really is our work about 4 steps to my future. And in today's presentation, I'd like to focus on some of the feasibility outcomes of this universal school-based mental health intervention that we delivered to 2 primary schools within the Western Cape. And I'd like to acknowledge all of the collaborators as shown on the screen, as well as our funders. And by means of background, I'd like to just touch a little bit on how it all began. And really, this was with a delegation from the University of Bath back in 2016. And in particular, making connections with Dr. Maria Lodes, who at the time had an interest in fatigue, and myself and Ashraf Kaji having an interest in sort of structural barriers to adherence to antiretroviral therapy, with a focus on looking at what this might look like in adolescence too, coming together with some research ideas there. And then also, once that work had been completed, finding ways in which, we could take things a little bit further, and soon came to realize that actually there is a real dearth for focusing on mental health research amongst children and young people. And so we put together sort of a proposal which we could have a look at the potential of universal school-based interventions, and we were able to make connections with community keepers, make connections with Paul Stallard and Prof. Helene Loxton towards developing something that we could then pilot and test to see whether delivering something like this is going to be possible within the South African school setting. And I'll talk a little bit more about the formative work as well. But this work really is also against the background and within the context of the state of mental health amongst young people in South Africa. And so even though there aren't any national prevalence data on the mental health problems of children and young people in South Africa, we do know from some important studies like that by Kleinkies in 2006, and based on expert consensus of national prevalence data, that there is a sizable proportion of young people thought to be living with a diagnosable mental disorder, at least within the South African context, and their estimates were at about 17%. And we know that their young people are considerable, as are the adult population in South Africa in general, at considerable risk for developing mental health problems, and young people in particular so, given their reliance on caregivers to help recognize and point them towards mental health support. And I'm aware of the audience that I'm speaking to that are very familiar with sort of the social determinants of mental health and all of the various risk factors that place young people as well as adults in our context at risk for developing these problems, and also against the backdrop of numerous barriers to help seeking. So barriers such as distrust in the healthcare system, stigma, broader social cultural factors, the financial costs of mental health, and also the time availability and resources within the public health sector. So really, the problem of common mental disorders in South Africa in particular is an issue, and there are some studies that point towards sort of anxiety rates amongst children, which I haven't captured here, but I'm happy to share with those interested, which shows that we really need to be able to focus our efforts on preventing anxiety and depression, which really is a major public health concern, and the early school years. So we're through the lens of prevention and early intervention, focusing on the early years, which is an opportune time to develop resilience skills in particular, and then finding young people where they are at, which is in schools. And schools offer a context which is accessible, which is perhaps less stigmatized than accessing mental health services, and certainly a place in which young people are spending considerable amounts of time, and these are then good opportunities to engage all young people and potentially deliver something at a universal level, whether that is to the whole school or to a particular classroom. And then against the backdrop of the various factors that place young people at risk for mental health issues, one does wonder sort of this distinction between whether what we are offering would in fact be something universal, or is it already at a more targeted or selected level, just given the context in which many young people grow up. So we aimed to develop and pilot test this universal program. And our formative work was really based on 2 phases, with 1 phase revisited, no thanks to COVID. And our first phase really entailed doing sort of a systematic review where we had to look at, what universal school-based mental health programs were available, to see whether, especially within an LMIC context, and to see what, if anything, had been delivered within the South African context, and we didn't find anything in particular. We then took from this an opportunity to ask children, their parents, their school counselors, as well as their teachers, about what such an intervention should look like, where the focus should be, who it should be delivered by, when it should be delivered. And we used all of this information together with some findings that we got about South African children's understandings of feelings, thoughts, and behaviors, given that the underlying theoretical framework for our study was based on principles of CBT. So we wanted to also have a look at that. So together, all of this information came towards developing the 4 steps to my future manual, which I'll describe the steps in the next slide, which was initially compiled then by Professor Paul Stallard, who has extensive experience in delivering school-based mental health programs in the UK. We used our qualitative information as well as some principles of CBT and programs that are focused on children and young people, like Friends in particular, and then also engaging with Community Keepers, who was a key NGO that we partnered with for this research. We then set out to want to pilot the program in 2020, and we sort of had to pivot slightly given COVID, and we used the opportunity to understand how young people experience the disease containment measures. And we used this information then towards developing a protocol that would be more suitable in the current context, to look at some feasibility outcomes. And so I'll report on some of the primary feasibility outcomes here, but we also did explore secondary outcomes related to whether there was any reduction in symptoms of anxiety and depression as measured on the RCADS 30, which is the revised Children's Anxiety and Depression Scale, but we also looked at self-esteem and emotion regulation, happiness and well-being, as well as bullying. But I'll report mainly on these feasibility outcomes. So this was a 2-armed randomized feasibility pilot trial, and we randomly allocated one school to be the intervention group and the other waitlist control. So we delivered this intervention then in 2021 to the first school in term 2 and to the second school in term 3. And we invited all grade 5 learners at the participating schools to take part. This sort of gives an overview of the trial design, but given my time, I'm happy to share the paper where this could be explained a little bit more in detail to those interested. Just by means of overview, 4 steps to my future, as you can imagine, entails 4 steps, each of which has 2 sessions. These are informed by, as I mentioned, underlying principles of CBT. So in terms of our first step, we really wanted to see, put a focus on valuing who you are and enhancing self-esteem. Thinking that you can, so promoting helpful thinking, helping myself to feel better, so looking at enhancing emotion and even self-regulation, and then making it happen, so that empowering goal-focused action and problem solving. So in terms of our feasibility outcomes, we looked at how many parents refused. We used an opt-out consent procedure, so only those parents who returned the consent forms and chose to opt out is how we obtain parental consent. We also looked at how many children declined. We then completed measures at baseline, post-intervention, 1-month follow-up. We were interested in how many groups received all of the sessions, how many children could attend all of the sessions, and whether they were delivered fully as intended. So we also did some exit focus groups. We used fidelity checklists by observers and also asked teachers what they thought about the delivery of the program for those teachers who chose to take part. So just quickly, this is our sort of summary table. We were able to have about 85% of the learners from the immediate intervention group take part and about 90% from the delayed intervention group. We were able to deliver all of the sessions fully as intended, except for one activity that we had that we removed. In terms of data collection and the measures that we were able to collect at the various time points, we could see that we were mostly able to collect data from all of our participants at all of the time points, except for our second school, where we were only able to have about 64% of them complete those measures. So something for us to think about then. Just in terms of delivery as well, at the first school, we were able to deliver the intervention over 8 weeks, 1 session per week as intended, but we also had a 1-month gap due to COVID restrictions to contend with. And at the second school, we were allowed 2 weeks to deliver the intervention. So it was a much different delivery method. So we will also, when we explore our secondary outcomes, have a look at whether this mode of delivery had any impact. So in terms of acceptability, the program was enjoyable. Children preferred their teachers not to be in class. They were be in the class when it was presented. Recall was relatively good, and they shared their the skills that they had learned with their parents and family members, which shows the potential for some ripple effects there. So overall, we found that these findings give us a really good idea of the potential of delivering programs like this. And certainly important is the help of NGOs that are like community keepers that are already embedded within schools that would help with the sustainability of interventions like this going forward. So I would like to acknowledge all of my collaborators and also say thank you to all of our participants.
Thanks so much, Bronwyne. It's really great to see all this amazing work with adolescents emerge, and congratulations to you and your research team to manage to I guess, leverage COVID despite its kind of complications to the research methods. You managed to pull it together. So congratulations.
Thank you.
We're going to move quickly to Dr. Claire van der Westhuizen and Ms. Megan Poole, who are our last presenters for the first session here. I have a feeling we won't be having questions. So if you do have questions, please put them onto the chats and we will get to them shortly. So Claire van der Westhuizen is the Deputy Director here at the Centre of Public Mental Health. She's a medical doctor by training and a researcher lecturer at heart. And she enjoys partnering with diverse teams and working towards bringing together mental health interventions within everyone's reach. And she's co-presenting with Megan Poole, who's a registered counsellor and a PhD candidate here at the centre. And she enjoys being involved in intervention work, particularly with adolescents. And her own research interest is in promoting the mental health of healthcare providers. So over to you, Claire and Megan.
Great, thanks so much, Kat. I'm going to stop our video while we present. So today we're going to be talking about two interventions, and these are prevention interventions. And what that means are we bring these interventions to adolescents who already experience some mental health symptoms, and then we're giving them intervention to help them with this. So we first want to talk about why we focus on adolescent mental health. Well, adolescence is a time of rapid development. And we also know that 75% of adult disorders will begin during adolescence and youth. And this really has an impact not only on adolescents functioning, but may also impact on their life, and that suicide is one of the leading causes of mortality in this age group. And also mental health is vital for healthy development in adolescence. And it also lays the foundation for a healthy adult life, and as well as laying the foundation for a healthy next generation. So this really does, investing in adolescent mental health really does bring dividends for generations to come. So I'm going to hand over to Megan.
Thank you, Claire. So the use, I'm going to be talking to you a little bit about the STARS intervention, which is the development of sustainable technology for adolescents to reduce stress. And the use of technology in combination with evidence-based psychological therapies may provide solutions to many of the barriers to access mental health interventions. And this is what the STARS project set out to do. So the WHO collaborated with partners in 5 settings, namely Jamaica, Nepal, Pakistan, West Bank, Gaza Strip, as well as South Africa. And the development process was guided by human-centered design methods, which incorporated feedback from adolescents, expert input, as well as literature reviews. So the end product was not a predetermined product, but involved, as I said, the human-centered design process, resulting in a chatbot, which is an online application that engages the user through messaging conversation. And I'd just like to give you a quick idea of how a chatbot works. So that was Meet Chommy, the chatbot. In South Africa, we did 3 small pilot studies with the chatbot. And our chatbot was called Chommy, meaning friend in 2 of the languages spoken in the Western Cape, namely Afrikaans and Xhosa. Chommy was designed to look friendly and gender neutral, and the intervention included psychoeducation, emotional regulation, behavioral activation, and problem solving, as well as consolidating gains. Adolescents used CHIME for 2 weeks, and we conducted pre and post interviews, collected using analytic data, and reviewed chatbot transcriptions as well. After using CHIME, the participants agreed that CHIME was largely acceptable. They felt that the character CHIME was relatable, and they looked like a real person or felt like a real person. They enjoyed simple language and the use of emojis, videos, and GIFs, and case studies to deliver the intervention content. So, of our pilot study, the third round, engaged adolescents completed at least 5 of the 10 sessions, and of the 20 adolescents, 12 were considered engaged, 60%. So the average number of sessions completed was 5.6, and of those who were classified as disengaged, technical issues with Facebook, data, and device issues were highlighted as barriers to engagement. Depression scores decreased in both engaged and disengaged users, and anxiety scores decreased in engaged users. So this is just a quick idea of a testimonial video of one of the chatbot users that we'd like to share with you today.
My name is Anthony Mafume. I am 18 years old. I am currently still studying. CHIME is like a very close friend. It really helps me emotionally. CHIME really had a very good impact on my life because it made me who I am today with all the things that I have learned from CHIME. Right now, I can be able to accomplish each and everything that I want.
So just a quick look at the video, and I'm now going to hand over to my colleague Claire to tell us a little bit more about Project Aspire.
Okay. Thanks, Megan. So Project Aspire was an intervention that was designed to address the mental health needs of adolescents in South African communities. And this was the intervention was really aimed at decreasing depressive symptoms and risky alcohol use. So there was a lot of formative work that happened before we moved to this feasibility trial. And we interviewed adolescents, caregivers, and stakeholders about how to adapt an existing motivational interviewing problem-solving therapy intervention, as well as barriers and facilitators to delivering this intervention in communities. And the adapted intervention was then tested in a feasibility trial. So we screened a number of adolescents, and those who screened at risk for depression and alcohol use were offered the intervention. So we did a baseline assessment in session 1 with 117 adolescents, and these adolescents were then randomized to one of 2 groups. The control arm was referral only for severe symptoms, and then the intervention arm had a further 3 sessions, and they were also referred as necessary. We followed the adolescents up at 6 weeks as well as at 3 months. So just to give you an idea of the intervention, so in session 1, which all participants received, we had the screening and assessment, and then they were given feedback on the screening. And then we used a motivational interviewing style throughout the session 1, but also to build rapport, and for those who were at risk for alcohol, to develop a readiness to change in those young people. For those with depressive symptoms, we used behavioral activation strategies. And then for the intervention arm only, we did a check-in using motivational interviewing, and they were taught the steps of problem-solving therapy. And we started with addressing the problems that are really important for the adolescents' priorities that can be changed in their lives. And they did an exercise with the counselor. Session 3 was about coping with negative thoughts, as well as coping with those problems that don't really impact an adolescent's life priorities. So the coping with negative thoughts was teaching them how to deal with this. And then we also brought in some emotion regulation here. And then the final session was about acceptance and teaching the adolescents to deal with problems that can't be solved, such as a chronic disease diagnosis or the death of a loved one. So things went really well in the beginning, and we only lost a couple of participants that were recruited right at the beginning of the trial in November and December 2019, and then COVID. So we did lose a few participants. We lost them to follow up during hard lockdown because we then had to shift everything onto online platforms or using smartphones. So we had to shift recruitment and all interventions away from face-to-face settings. So when you look at our feasibility outcomes, this did affect us a bit in that 2 of the outcomes weren't fully met, and that was the feasibility of recruitment, so the rate of recruitment, and this definitely took a dip as we had to shift over, as well as the retention within the intervention. But when it comes to the other measures of data collection and counselor competencies and dropouts after randomization, those were all met and we had no issues there. If we look briefly at the clinical outcomes, this really wasn't the focus, given that this was a feasibility trial. Both groups showed decrease in depression and alcohol at both time points. And for anxiety, at 6 weeks, we found the intervention group decreased far more than the control group did. So we're really hoping to move this forward to a fully powered randomized controlled trial. We know there's a great deal of work being done in refining these interventions and a number of other programs by colleagues around the world. And so there are many good ideas in the pipeline from adolescents themselves, as well as from people partnering with them. So we are hoping and expecting these interventions to play a role in improving adolescent mental health. And I just want to acknowledge the broader team for both these projects. Thank you.
Well, thanks so much, Claire and Megan. It really is nice to see all these different sort of types of interventions that are being developed and tested. Because as you know, with adolescents, it's also about sort of the acceptability and what they would prefer. You know, it's not always going to be a one size fits all. So that's wonderful. We do not have time for questions at this stage, so I am going to hand over to Claire, who's going to be facilitating the second half of today's webinar, who will be introducing our first speaker. Over to you, Claire.
Great, thanks so much, Kat. All right, so our first speaker in the second session is Crick Lund, who is the co-director of the Centre for Global Mental Health at King's College London and an honorary professor in the Centre for Public Mental Health here at UCT. He's a clinical psychologist by training and has been working for over 25 years on mental health policy and services research in low middle income countries. So welcome, Crick.
Thanks very much, Claire. I just wanted to check you can hear me okay?
Yes, we can hear you.
Okay, great. Right, good morning, everybody, and happy World Mental Health Day. I hope you're all doing well. And thanks for the opportunity to share with you some of the work that we've been doing in the ASSET study. So this is the work that I'm sharing as part of a broader project on health system strengthening in sub-Saharan Africa, which was led by Martin Prince, and did work in 4 African countries. And our particular piece was focused on strengthening health systems to integrate mental health into routine antenatal care in Cape Town. So here is the wonderful team that made this all happen, and I'm really just speaking on behalf of the team. I don't think I've got time to go through all of the names, but just a huge thank you and acknowledgement to everybody who made this work possible. The overall aim of the project was to develop and evaluate a health system strengthening intervention for pregnant women with psychological distress and experiences of domestic violence in Cape Town, South Africa. There's been quite a lot of epidemiological work showing very higher rates of psychological distress, both antenatally and postnatally in Cape Town. I think with prevalence rates ranging from 20 to 33%. And much higher than in high-income country settings. We also know quite a lot about what works in terms of psychological interventions to improve psychological distress and experiences of domestic violence. But we don't know a lot about how to strengthen health systems so that these interventions can be delivered routinely as part of antenatal and postnatal care. And so this was really the focus of our project. The study began in 2018 with a diagnostic phase, really trying to assess and understand more about the care environment in midwife obstetric units and basic antenatal care clinics in the Cape Town metropolitan area. We then went through a development phase of developing the intervention, working closely with colleagues in the Department of Health and linked NPOs. And then we conducted a pilot and intervention phase, and that's really what I'm going to be sharing with you today. So it's really important with health system strengthening work to be very involved and engaged with all the different stakeholders right from the beginning. And these pictures show some of the meetings that the project coordinator, Dr. Zulfa Abrams, was involved in. And we all engaged with staff from the MOUs and from the bank clinics, from facility level all the way up to senior management. We established a working group, which comprised members of the Department of Health as well as the research team, to really regularly review the progress of the project and to develop a common understanding and also a shared ownership of the intervention. So a really important part of this process was a theory of change workshop. And for those of you who are not familiar with theory of change, it's a wonderful method, first of all, of obtaining a high level of participation from all the different stakeholders involved. And what it enables you to do is to identify a particular impact that you hope to achieve through your intervention, and then to work your way backwards to identify the long-term and then the short-term outcomes, as well as all the different intervention components. It really helps you to critically engage with your understanding or your assumptions about how you think your intervention will work. And it also enables you to develop an evaluation design by identifying some of the key indicators at the various stages along the causal pathway. So on the basis of this engagement process and the theory of change workshop, we then were able to identify some of the main health system strengthening changes that we wanted to put in place. And just very briefly, these involve, first of all, health promotion, whereby health promotion officers conducted awareness talks to improve mental health knowledge, decrease stigma, and improve health-seeking behavior. And these were delivered to pregnant mothers and their families waiting in queues in the clinics in the mornings, as well as information handed out in brief leaflets. Then secondly, antenatal care nurses were trained to screen pregnant women for symptoms of psychological distress and experiences of abuse. We had some help in that. In the maternity case record, there are forms for screening for depression and anxiety, and also for domestic violence. So it was a process of strengthening that system, which was already in place, by providing training and ongoing monitoring of detection. We then put in place referral pathways, or strengthened referral pathways where these did already exist, referring pregnant women who screened positive for either depression or anxiety or domestic violence to NPOs, supporting the facility in community outreach, and also strengthening referral to mental health nurses or medical officers where this is required. And then finally, we trained and we developed a counseling booklet to train community health workers to provide 3 structured counseling sessions using problem-solving therapy to pregnant mothers in their homes. So this was a pilot trial, really focusing on implementation outcomes. We weren't adequately powered to assess effectiveness outcomes, and we emphasized and made a lot of use of implementation science frameworks for this evaluation design. And we implemented in 3 antenatal clinics in the Cape Metro. And these are shown on this map. They were the Retreat CHC, the Gugulethu CHC, and Nomzamo CHC. And as I mentioned, we used implementation science frameworks, and I just wanted to recommend this template for intervention description and replication, or TIDIA framework, which is a really wonderful method for helping you to organize the different components of your intervention, clarify the rationale and theory, and also all the materials, the procedure, who would deliver, and so on. I'm not going to have time today to go through all of this, but if you're interested, please do have a look at this article by Cottrell and colleagues called Getting Messier with TIDIA. We then implemented a number of different study designs, and in the interest of time, I'm not going to be able to go through these in detail. Just suffice to say there was a repeat knowledge, attitudes, and health-seeking behavior survey. We assessed healthcare workers in terms of their organizational readiness, pre- and post-training knowledge tests, stigma, burnout, job satisfaction, and quality of life, and we published those findings separately. We conducted file reviews of the maternal case records. We conducted a small cohort study to follow pregnant women until 4 to 6 weeks after they'd given birth. And then we did case studies of the facilities and the NGOs and did qualitative assessments, including interviews and focus group discussions with pregnant women and health workers at each level of the intervention. And then we finally did assessments of how the counseling was delivered by the community health workers. So to put all of this in place, we were really keen to make sure that we left some sustainable skills, and we left a sustainable training and supervision platform. And so we started with master training for the awareness raising, for the detection and referral, and for the counseling components. And the details of this are set out in the final outcome evaluation paper, which I'll share with you in a moment. These are just some pictures of the training manual and the group. And then that training was then cascaded down to the people who were involved in actually delivering the interventions. So the health promoters for the morning talks, the antenatal care nurses for detection and referral, and then the nurse coordinators and community health workers linked to the NGOs providing the counseling in the mothers' homes. So very briefly, unfortunately, don't have time to go into a lot of detail, but please have a look at this paper if you're interested, led by Zulfa, which sets out the implementation outcomes of this study. Just very briefly to say there was good acceptability and appropriateness of the different intervention components, and we aggregated data from the quantitative and qualitative parts of the study to come up with these overall assessments. But we had some quite major challenges with the feasibility, especially around the screening and detection component of the intervention. Antenatal care nurses were already very overburdened with their existing clinical load, and it was difficult for them to find the time. And many of them were experiencing challenges themselves with high levels of burnout and stress. However, having said that, for those women who were detected, referred, and did receive counseling, there was good fidelity of receipt of the counseling and good qualitative feedback that once the counseling was delivered, women actually found it to be very beneficial. There were some challenges around confidentiality of delivering counseling in the home, which I can answer questions about if you're interested. So our recommendations going forward were to the Department of Health to strengthen awareness raising among antenatal mothers and families through health promotion talks, to appoint dedicated lay healthcare workers in the facilities to support the screening and referral, and if necessary, provide counseling on the same day. We saw a lot of attrition of mothers who were detected, but weren't followed through because of the delay in time, and often because the particular need that they had expressed in the facility seemed less relevant to them when we were able to follow them up further down the line. We also recommend that there's psychosocial support provided for antenatal care nurses who needed a lot of support in this area. So again, just to acknowledge the team, here they are named, and really for all their wonderful contributions to this work. If you want to find out more, please do have a look at the Health Asset website, and also to acknowledge our funder. Thanks very much, Claire.
Great, thanks so much, Crick, for that whistle-stop tour of assets. I know it's very hard to put such a whole lot of amazing work into 10 minutes, so thank you. I'm now going to ask Noma to start sharing her screen while I introduce her. So Noma Moshani hails from the Eastern Cape, and her background is in psychology, education, and self-leadership. Her interest is in research because of the power it has to help us uncover our social and personal conundrums. And she particularly likes the area of public mental health because of the opportunity it affords us to proactively tackle mental health problems and promote mental wellness. So thanks so much, Noma. Go ahead. Noma, I can't hear you. Noma, you're on mute.
Okay, all right. Hello, can you hear me now?
Yes, I can hear you now.
Okay, all right. Thank you for lending me an ear while I share my research journey under the topic of Indoda, iyanyamezela, a man perseveres. Families are very important when it comes to the well-being of the individuals within the family. However, in South Africa, more than 42% families are headed by females, and it's only a few families that are led by men, especially when a mother is not around. And the issue of father absence is very problematic, especially in the context of Xhosa culture, whereby a father has to play a key role in culturally guiding children throughout life. This is even particularly important when it comes to the period of going to initiation. That is the period whereby a boy transitions from boyhood into manhood. And during this process, mothers or women in general are usually not allowed to take part in this process. And this is making the scourge of father absence to be even much more difficult for the young men. Well, the aim of this study was to explore the experiences and the perceptions of Xhosa young men who transition into boyhood, into manhood, without having a present or an involved father. The second aim was also to get the views of the Xhosa male elders on what they think about the importance of having a present or an involved father during the process of going to initiation. And then lastly, this study sought to identify the support needs of the Xhosa young men during this period. And this research was qualitative. We had 27 semi-structured interviews, individual interviews with Xhosa young men from Khayelitsha, and 5 individual interviews with the elders who were also from Khayelitsha as well. And we used thematic analysis in order to make sense of the data. And during this research, it was very important for me to position myself and to also locate myself both as an insider, as an outsider as well, being a woman who was tackling a cultural sensitive topic, which also involved the conversation around going to initiation. And culturally, this is a very sensitive topic. And also the other challenge was the fact that the issue of father absence is not something that is adequately addressed or something that is discussed. So it meant that I was tackling a topic that is hardly spoken about. So therefore I had to position myself quite well as a researcher and to respect the participants when sometimes they feel uncomfortable with some of the themes that arose. Well, when it comes to research ethical consideration, informed consent was received from all participants, and it was emphasized that they have a freedom to withdraw at any time should they feel uncomfortable, especially tackling a topic of this kind. And also confidentiality and privacy was ensured. Because of the nature of this topic, there was an opportunity for distressed participants to get a referral should they feel that the topic had caused some triggers to them. Well, the results are showing us that initiation is a very important period, especially among the young men who have absent fathers, because it gives them an opportunity to be the men that their household previously didn't have. But on the other hand, it was also indicated that it is also a sad reminder, because as a cultural sensitive process, a mother would not be involved no matter how much she would like to be there and assist the child during this sensitive process. And also it was also indicated that they would have loved to gain assistance and guidance from their biological fathers as they're about to step into adulthood or into manhood. also there was an issue of clan names, the questions that when you go through initiation as a person who doesn't have a present or involved father, or not using his or her, his surname or clan name, that means that there were worries that maybe during the process, there are certain processes that might not done in a particular way because the maternal family and the paternal family, they conduct those processes differently. And then it was indicated that even though social fathers do play an important role in terms of being there and stepping in and stepping up to help in the absence of the biological father, however, there was always that void that someone who was supposed to be present is not present in this process, and the time of initiation was a painful reminder of such absence. So one of the participants indicated that when you don't have a father, sometimes as a young man, it feels like you are a lone tree that is standing alone, being blown by the wind side to side without having guidance or being grounded. And as a result, the impact of father absence was associated with depression. Some of them spoke about depression and anger as well, out of not having someone to guide them. And when it comes to the implication for practice, research, and policy, from this research, it was clear that when it comes to fatherhood, because of the changing times politically and economically that we're in, it's important that fathers embrace the role of being present emotionally more than worrying about their inability to provide. And also it was indicated that it's important for them to swap roles with the mothers so that the responsibility of parenting is shared by both parties. And also on the side of mothers, it was indicated that it's important for mothers not to hide the paternal identity of the child, irrespective of what has happened between her and the father, because that thing, it causes the child to feel a little bit disoriented culturally, especially not knowing the clan name of the father. So it's also important that we create platforms whereby children, not just boy children, whereby children could be reunited with their fathers. And also when that doesn't happen, it's important to have spaces whereby the young men in particular get opportunities to be exposed to well-meaning role models, social fathers, and mentors. So in conclusion, indeed, this study confirms that father absence is a crisis, and it affects Xhosa young men negatively, especially around the time of initiation. And initiation also, as much as it is an important moment for them, but at the same time, it also brings an emotional baggage, or it highlights the uninvolvement of the father. So interventions are needed, but not only for the young men, but for the mothers as well, and the absent fathers themselves. Thank you so much.
Thanks so much, Noma. That was a really, for presenting on your really fascinating study, and I think in record time as well. So well done for that. So now we're going to move on to Thandi. Thandi, I'm going to invite you to share your screen while I introduce you. So Dr. Thandi Davies is affiliated with our center as a qualitative researcher. Her research interests are task sharing, perinatal mental health, qualitative research, and integrating mental health care into life skill adolescent interventions. So welcome, Thandi. We're looking forward to your talk.
Thank you so much, Claire. I just want to check that you can hear me.
Yes, I can hear you.
Great, thank you. Hi, everyone. It's great to be presenting today. So my talk is going to be on the impacts of COVID-19 on mental health care service provision in the Western Cape, and it's called the MASK study. So against the backdrop of an already constrained mental health system, this study conducted an investigation of the impacts of COVID-19 and related lockdown measures on public mental health service provision in the Western Cape. It was conducted in collaboration with King's College London and researchers from 6 other low and middle income countries who also conducted the same study in their own countries. We used a mixed methods design and triangulation of data from surveys, interviews, and district health information system data. We had 22 stakeholders who were in our sample, and this included NGO directors, public sector psychiatrists, psychologists, mental health nurses, counselors, and an occupational therapist. The time frame covered was 15 months from the start of lockdown, which happened, as you know, on the 26th of March, 2020. And then analysis involved triangulating data and verifying it across the 4 different measures. And then we conducted member checking, where preliminary findings were presented to the participants and points of dissonance were discussed, and then consensus was found. So there were 6 categories of results that we kind of found. First was challenges experienced by people with mental health conditions at the community level. Second, changes in mental health service provision at all levels of care. Third, changes in provision of therapeutic services. Fourth, changes in the mental health care needs of frontline workers. Fifth, innovations or modifications to deal with the challenges. And lastly, the recommendations. So the first theme was challenges experienced by people with mental health conditions at the community level. And there were just so many, as you all, I'm sure, are aware of. And they included decreased income, increased food insecurity, travel restrictions, fear of catching COVID on public transport and at clinics, closure of substance abuse and opioid detox centers, closure of protective workshops and therapeutic groups at NGOs, a reduction in social support and food supplements from schools for children and adolescents, and the cigarette ban also had a big impact. And all of this led to reductions in clinic attendance, reductions in collection of medication, increased vulnerability to stress, distress and mental illnesses, reduced access to food and shelter for homeless mental health care users, major impact on patients' mental health, and a really dramatic increase in relapses. So one psychologist said, between COVID waves, there would be a kind of psychiatry wave, a sort of mental health storm that felt like a tsunami. Second, we looked at changes in mental health service provision at specialist and district hospitals and at primary care. So at specialist hospitals, inpatient services stayed open, but the threshold for admissions was raised. And inpatient inpatients were discharged early. Voluntary admissions were turned away, and emergency acute admissions were prioritized. And then family visits weren't allowed in the wards. In addition, there were inadequate quarantine spaces in the psychiatric hospitals, which meant that sometimes PUIs had to be admitted into wards before knowing their COVID status, resulting in several COVID outbreaks in psychiatric wards. Outpatient services were reduced drastically, emergencies were prioritized, and then time periods between visits were extended, and specialists provided longer scripts. At district hospitals, inpatient psychiatric beds were cleared for COVID care, admissions were reduced, and patients were referred straight to psychiatric specialist hospitals. But the specialist hospitals themselves did not have space, and so many patients were kind of warehoused without specialist treatment or care, waiting for beds in the already strained specialist services. Outpatients at district hospitals were generally not seen by doctors and were sent straight to pharmacies to collect their medication without consultations. Similarly, in primary care, initially patients were only seen outside the clinics, and nurses sent them straight to collect their prescriptions at pharmacies. Only emergencies were seen by doctors, and there were also extended periods of stockouts of psychotropic medications, which caused psychiatrists and mental health nurses huge headaches to try and scramble for alternative medicines, some of which were literally antihistamines. So these are just 3 graphs that we put together from the DHIS data. And you can see where the red line is where COVID started and where lockdown started, and just the drop in admissions and visits to the hospitals and the primary healthcare centers. And you can also see the kind of waves that came subsequently, and then the drops again with the various COVID waves. And these graphs really help to illustrate and endorse the data and stories we were receiving from the interviews and surveys. So lockdown had the greatest impact on therapeutic services, with almost all inpatient and outpatient therapy being closed. Distressingly, as you can see from the graph, therapeutic services did not return to pre-COVID levels for another 1.5 years, despite lockdowns being revoked. So then changes in mental health needs for frontline workers. There was a drastic rise in mental health care needs of frontline workers. This was compounded by the various lockdown regulations, which hindered frontline workers from accessing their normal coping strategies, such as attending the gym, religious, family, or social gatherings. No formal positions were established at facilities to provide psychological support to frontline workers, with the exception of a psychologist position created at Fortescue, which was great. So just quickly looking at the implications of all these changes in services, there was reported a dramatic rise in relapses, as I mentioned, increased family burden for caring for mental health care users who were no longer able to be admitted or seen for therapeutic services, a subsequent increased community stigma because of relapses and mental health care users being kind of more present in communities, increased isolation for mental health care users who were in hospitals and couldn't get visits, increased subsequent burden on the mental health system with the psychiatric waves, and then decreased ability of healthcare workers to provide support. Hospitals and clinics created innovations to deal with some of these challenges. So some of these included the addition of oral psychotropic medication to the essential chronic medication list, which enabled delivery of medications to patients' homes. And this really was a breakthrough in general for community psychiatric services. Then there was also the establishment of hybrid telephonic and face-to-face consults. This worked well, particularly for chronic patients who were already known by psychiatrists and psychologists. This also reduced transport costs for patients. There was the provision of longer prescriptions for chronic psychiatric patients, and also virtual patient-family liaisons. For example, Quentin the robot. I'm not sure if any of you heard of Quentin the robot, who was an iPad on a robot that came to patients so that they could speak to their families and also have virtual consultations. This relieved pressure from district specialists who normally needed to visit many different hospitals at one time. Teaching was also conducted online for interns and registrars, and guidelines were created for virtual psychotherapy for registrars so that they could conduct virtual therapies. Lastly, recommendations that we got from the study for both COVID pandemic and the general mental health system. In terms of COVID, policies need to be created for managing COVID in psychiatric facilities. Therapeutic wards need to be kept open and not used as spaces for general COVID care. Policies need to be created for providing consistent care for mental health care users during lockdown periods. And psychological therapeutic treatment needs to be reclassified as an essential service that cannot be shut down, ideally with protocols to fast-track psychiatric patients. In terms of the general mental health system, one of the psychiatrists said, what COVID has done is it's pulled the scab off something which would never have been allowed. It has exposed the gross inequity or the under-resourcing of the system. There is absolutely no slack in it. There is no give in it. So the first recommendation coming from these particular findings is to improve funding for the mental health sector. Service providers are under severe strain due to poor infrastructure and unfilled specialist posts, leading to decreased quality of care across the board for mental health care users. The second is to create and implement a plan for managing stockouts of psychotropic medications and ensuring that these incidences do not occur. Third, to create positions for professionals to provide mental health services for staff at hospitals and clinics. And lastly, to create policies relating to social and economic support for mental health care users as a particularly vulnerable population. And in finishing, I would just like to say thank you to the specialists and members of the Western Cape Department of Health who took time out of their highly pressurized work environments to participate in the study. And thank you so much to Catherine Sorsdal and Charlotte Hannon for the support in conducting this study. Thank you.
Great, thanks so much, Thandi. That was really, really fascinating. It's good to hear insights from our patient-facing colleagues and also to hear some of the solutions that they implemented. That's really great. Thanks so much. I'm now going to invite Roxanne and Margie to start sharing their slides while I introduce them. So Roxanne Jacobs is a research officer at CPMH at UCT. She's been involved in various public mental health projects that include research on aging and dementia, elder abuse, and violence and injury. And today she's going to talk about her work on the STRIDE project, where South Africa was one of 7 participating low middle income countries. And she is joined by Margie Schneider, who recently retired from UCT. She was the deputy director of our center up until her retirement. and obviously an integral part of CPMH for many years. She was also the lead on the South African component of the STRIDE project. So welcome, Roxanne and Maggie. We look forward to hearing your talk.
Thank you, Claire. So today I'm going to talk about Dementia in South Africa and provide a summary of some of the key findings from the STRIDE project. So the work presented here was, of course, a team effort, and we'd like to acknowledge the contributions of the larger team. The names are listed on the screen. The project was also led by the London School of Economics and then funded by the Global Challenges Research Fund. So just very quickly, what is dementia? Dementia is an umbrella term for several diseases affecting memory, other cognitive abilities, and behavior that interfere significantly with a person's ability to maintain the activities of daily living. Although age is the strongest known risk factor for dementia, it is not a normal part of aging. So just in terms of a little bit of background, a global paper, a paper estimating the global prevalence for dementia estimated about 50 million people are currently living with dementia. And as people are living longer, it's expected that this number would increase to just under 153 million by the year 2050. In South Africa, we have not conclusively established dementia prevalence in South Africa. We currently do not have a dementia policy. Also, there's unequal access to healthcare and support services with the urban biases in terms of resources available for the country. And then, of course, there's a lack of awareness of dementia being a health condition. So basically, South Africa needed an evidence base to inform priority setting for adequate responses to dementia treatment, care, and support. And this is where the STRIDE project came in. STRIDE is a project that aimed to strengthen responses to dementia in 7 low and middle income countries, of which South Africa is one of the participating countries. So we worked with Brazil, India, Indonesia, Jamaica, Kenya, and Mexico. So the overall aim was to contribute to improving dementia care, treatment, and support systems so that people who are living with dementia are able to live well, and their family and other carers do not shoulder the excessive cost or risk impoverishment or compromise their own health in caring for someone who's living with dementia. So the 7 countries, we all did different work packages, but they all started off with an in-depth situational analysis and did some work on stigma, unpaid care, prevalence, and social impact. We also did some work on models of care and costs, and then policy recommendations. This was all in the move towards the development of a national dementia plan for each of these countries. I'm not going to go into detail with methodologies followed. You're welcome to ask questions, but just for the context to the findings that I'm going to present here, we collected data through covering a range of topics in the in-depth situational analysis, which also fit into the global, the WHO's Global Dementia Observatory. We also interviewed a broad range of stakeholders. Yes, we included people living with dementia, the carers, government officials, a traditional healer, participants from the long-term care sector and the aging and social care sector. We also did some qualitative work on stigma and dementia, where we interviewed people living with dementia and carers, healthcare workers, and the general public. And then we did a prevalence survey, a household survey across 2 regions in the Western Cape and the Limpopo province, where we interviewed both older adults and informants across 4 languages: English, Afrikaans, Xhosa, and Sepedi. So some of our key findings. In terms of access to diagnosis, we know that we have a fragmented healthcare system. We found that participants were talking about an unequal access to diagnostic capacity amongst practitioners themselves, as practitioners in their training don't get the same level of exposure in terms of geriatrics, are not always able to identify dementia. So this often led to misdiagnosis or delayed diagnosis. And delayed diagnosis was twofold, basically. Practitioners either misdiagnosed or believed that persons were too young to have dementia. And on the other hand, families didn't seek help because they believed it was part of a normal aging and only waited till the later stages, up until symptoms became quite severe and unmanaged before they actually sought help. And this, of course, led to an increased risk for elder abuse and neglect. In terms of long-term care services and support, specialized services that do exist for dementia are often in the private sector and largely inaccessible to the majority of South Africans because it's quite unaffordable. It's quite expensive. So the need for long-term care, we found that is really, it's at the community level, it's home-based, and there's not enough of these services available in the community sector. And those NGOs that do exist, or faith-based organizations that do exist that provide these services, are currently based on a failing funding model. This gave rise to the mushrooming of all these unregistered facilities and also increasing risk for elder abuse and neglect. In terms of post-diagnostic support, these are offered in pockets across the country and also with the urban bias. It's also because there isn't great dementia awareness. Like we said, there's a shortage of community-based services that people can be referred to, and again, an urban bias. So largely, people living with dementia are based within the home, which is a good thing because of philosophies like aging in place and active aging. We want to promote that people live in their own communities for as long as possible. But if unsupported and relying on often a female member who is unpaid, who often has to quit a job to provide care, that becomes a risky situation or not an ideal situation. Symptoms often go untreated because of costs. The medications that are available for managing symptoms are often not available in the public sector, and it's reliant on out-of-pocket payments, which is largely unaffordable to most families in South Africa. Some of our stigma work found that stigma and social cultural factors play an important part, especially in help-seeking behavior. We found that internalized stigma, public stigma, and structural stigma was quite significant. It was quite high. And this often led to hiding in isolation and families largely being unsupported. Stigma delayed help-seeking behavior and diagnosis. And we also found that traditional healing, of course, was the first port of call for many South Africans. Dementia in these settings are often confused with ancestral calling. So what's understood in terms of ancestral calling, it is usually understood as this unusual perceptual experiences where ancestors are believed to call an individual to become a traditional healer. The traditional healers we spoke to indicated that it's rare for ancestral calling to occur in older persons. It's not impossible, but it's quite rare. But with training, traditional healers can learn to distinguish the difference between dementia symptoms and ancestral calling and be quite a valuable source of support for families. Also, with training, medical practitioners can recognize the importance of traditional healers in communities and understand that family consultation is very important and not just rely on individual approaches, as family-centered approaches are more acceptable in cultural context in our country. So from our household survey in Limpopo and the Western Cape, we found a dementia prevalence of about 14.5% for the sample. And when we weighted that by national age, sex, and literacy estimates, that figure decreased to about 12.5% for South Africa. That's much higher than what the global studies has estimated for the sub-Saharan regions previously, which ranged between 2 to 4%. We didn't find a significant difference between males and females, and we did find the age expected trend as there's a greater likelihood of dementia in older than in younger cohorts. When we looked at diagnostic services people accessed, we found a lack of diagnostic services for dementia when compared to diagnosis accessed for other illnesses, for example, hypertension, diabetes, heart trouble, and stroke. As you can see on the screen, only one person in our sample actually received a formal diagnosis. When we looked at care needs, we found that need for care and support lies at community level, especially considering that most identified cases of dementia did not receive a formal diagnosis. Carers were mostly family, female, and occurred within a network of carers, mostly 1 to 2 carers. We also looked at elder abuse. We asked both older adults and informants about abuse using the elder abuse screening tool and the caregiver risk to abuse and neglect screening tool. what we found was that about 10% of older adults screened positive for elder abuse, and more than half of the carers screened positive for risk of abusing, which is quite high, of which about 14% was high risk. In other words, they scored 4 or more on the case. We found that people living with dementia were 4 times more likely to be at risk of abuse from carers compared to those without dementia. So in summary, some of our takeaway messages: dementia prevalence is high and increases with age. So in other words, we need to really start addressing some of those modifiable risk factors across the lifespan. Diagnostic services for dementia compares poorly to that of other diseases. And we also found that a delay in diagnosis was linked to increased risk of elder abuse and neglect, and therefore the prevalence for elder abuse and the risk of abusing was confirmed to also be very high. Aging in place is culturally appropriate, but currently unsupported, and therefore posing risk if not supported at community level. So community-based services are needed, and these services need to be sensitized to dementia. In other words, we need to really start leveraging existing community sources of support, include traditional healing faith-based organizations into community-based services to expand that level of support that we can provide at community level and at the home level. Addressing stigma is critical. This is basically essential for strengthening existing health systems, promoting help-seeking behavior, supporting early diagnosis, and improving quality of life. Last week, we launched the Stride Anti-Stigma Toolkit, where we provide a practical, interactive toolkit that includes real-life case studies and videos from people living with dementia and their care partners. What we've put together here is the work combined from the 7 countries, and it is based on the voices and experience of people living with dementia and care partners themselves. So basically, this is the link, if you're interested, that you can check out the toolkit. It's quite interactive. It gives you access to the findings of the 7 countries from the Stride project. It gives you some examples of how to work with people with lived experience, what are important considerations, how to select your target group, and it also provides a library of different visual materials and videos of people living with dementia and their carers sharing their experiences in how they dealt with stigma and overcame stigma. So you're welcome to check that out. And that's all from us, the South African team. There we go. Thank you.
Great. Thanks so much, Roxanne and Margie. Thank you. That's a fascinating study, and I think obviously an overview of a really comprehensive project and filling a major gap in low middle income countries. So thanks very much for that. Unfortunately, I don't think we've got any time for any questions, but I just want to say thank you to all of you for attending and for all of our speakers. It's been really, really fascinating. We would love to answer questions, however. So if you have any questions for us, please email us. There's contact details on our website as well. Or if you know one of the speakers, I think it's quite easy to find us. You can email us with your questions and we'd be more than happy to answer them. But yeah, thank you again to everyone for attending. It's really great to be part of a global community that's working towards making mental health and well-being for all a priority. So it's really great to have you with us today. Thanks very much.